Welcome everybody to the JJ&J academic program. It's February and we are ready to unlock 12 lead ECGs. What is an electrocardiogram or ECG? It's derived from the Greek terms electro, relating to electrical, cardia, which is related to heart, and of course graph, which is related to write. It was invented by Willem Einthoven, a Dutch scientist, in 1895. He won the Nobel Prize for medicine for this invention. Have a look at the screen at the almost 300 kilogram machine size and the very cumbersome saltwater baths that some hands and feet had to be in to create a neutral. Thank goodness we don't have to go through this anymore. Tens of thousands of electrocardiograms have been taken over the years and we use them on a daily, if not even more regular basis. Okay, so what is the indication for taking a 12 lead ECG? Some of the most common ones in the critical care environment is chest pain. But think about, what if you have a patient that's ventilated or perhaps cannot talk? Maybe flash pulmonary edema that's unexplained could also be an indication if you suspect MI. Dysrhythmia, before and after cardioversion, if your patient suddenly has a different rhythm, it's a good idea to do a 12 lead ECG. We could also have an ECG done pre or post procedure, like after a CABG or before and after an angiogram. Another reason could be routine, where we do a daily ECG. Please discuss with your treating doctors when you might stop this if there's a prolonged stay, but this will be in the more acute side or acute setting of cardiac patients or cardiac patients that are receiving medication that can affect the ECGs, like Quarter-X, for example. Okay, so how do we obtain a 12 lead ECG? We need an ECG machine. There's a nice picture of one that's more current. Usually has a tangle of leads wrapped around there. Please make sure that it's not tangled, that it's well looked after, and of course clean. We need 10 ECG stickers or electrodes, and of course 10 leads. But hang on, how does that work? We said 12 lead, and I'm saying 10 of each. It will all become apparent shortly. First step is to start with your 4 limb leads. And tips for this is to avoid electrical device contact, cell phones, etc. Avoid metal. Look for any breakages in the leads that could cause interference. Shave your patient's chest hair if they have, so that you can get proper contact. Place the right and left arm leads just underneath the clavicle. You are allowed to place them on the patient's wrists as well, as long as you keep it consistent. So not one clavicle and one wrist. Stick to the wrists or just under the clavicles. Then we place our neutral and our foot leads just above the iliac crest, which is above the bony areas of your hips, underneath the umbilicus. Avoid dressings, pacemakers, etc. And like I said, stay consistent. I think in most of our EDs and ICUs, we see people placing the limb leads on the chest area, so under the clavicles and above the iliac crest. Next up, we do the 6 chest or precordial leads. Precordial just means above the heart, basically, or around. Okay, so we call these V1, 2, 3, 4, 5, and 6. All right, so let's start with V1. Find the 4th intercostal space and place that V1 to the right of the sternum. V2 in the same 4th intercostal space and to the left. Skip V3 for now and go on to V4, which is the 5th intercostal space at the midclavicular line. So in the middle of that left clavicle on the 5th intercostal space. V5, still at the 5th intercostal space, but now we're at the anterior axillary line. And V6 on the left mid-axillary line, directly under the midpoint of the armpit. If you come back to V3, you just place them in between V2 and V4. So how do 10 leads become 12? The right leg lead doesn't take part at all in the electrocardiogram as far as vectors are concerned. It acts as a neutral, as the saltwater bath that Eindhoven used. And we just use our right arm, and left leg to create Eindhoven's triangle. These three leads create 2 views each practically, and thereby we get 6 views from the 3 leads. And together with the 6 precordial leads, we get 12 different leads in the end. So how it works is the ECG machine changes the polarity or poles of these electrodes and reads it from 2 different angles. So in lead 1, for example, on the slide, it creates your left arm to be positive and your right arm to be negative. It looks always from positive to negative, and it will measure any electrical charge coming towards it and produce lead 1. The next one, for example, lead 2, uses your left leg as positive and your right arm as negative, and does the same thing, giving us an inferior view from the bottom. Lead 3 uses that left positive leg lead and changes your left arm to negative, and also creates an inferior view going towards the left side and giving us lead 3. The AVF, AVL and AVR leads are quite special in that it creates one side of each of the triangle to be positive at any given point, and then the other 2, it creates basically an average or sum of the electrical charge and looks towards the middle of both of them. If you look at the diagram there of AVF, it uses the foot lead to act as positive and looks up at the 2 arms negative and gives us a more perpendicular view, if you will, of the inferior side. The same principle then applies to AVL and then AVR. Okay, so what are all these red and white little blocks about? What do they represent? So in any graph, you have an X and a Y axis, and our X axis that's going horizontally is representing time. We are also using large and small blocks in an ECG, and one large block is 5 millimeters in length. That equates to 0.2 seconds, which is 0.04 seconds for each small block times 5. So just remember, a small little block is 1 millimeter in length and represents 0.04 seconds of time. Every 5th one has got a darkened line, and that will give you 0.2 seconds. So that's time. Height is all about electricity, or the amplitude is all about electricity and millivolts. One small block, 1 millimeter high, is 0.1 millivolts. Our ECG machine also creates a calibration mark that looks like a big rectangle and will show us, similar to what's on this diagram here, 10 blocks high and 5 across, which means it's been calibrated to these kinds of settings that I'm talking about now, where 10 blocks equals 1 millivolt in amplitude. Small block, 0.1 millivolt, 10 small blocks creating 1 millivolt in amplitude. Okay, so before we get started with the electrocardiogram, let's just have a look at the conduction system, and we're going to show you guys a video from Alea Health all about that conduction system of the heart so that we can better understand what we are recording.
The cardiac conduction system consists of the following components: the sinoatrial node, or SA node, located in the right atrium near the entrance of the superior vena cava. This is the natural pacemaker of the heart. It initiates all heartbeat and determines heart rate. Electrical impulses from the SA node spread throughout both atria and stimulate them to contract. The atrioventricular node, or AV node, located on the other side of the right atrium near the AV valve. The AV node serves as electrical gateway to the ventricles. It delays the passage of electrical impulses to the ventricles. This delay is to ensure that the atria have ejected all the blood into the ventricles before the ventricles contract. The AV node receives signals from the SA node and passes them onto the atrioventricular bundle, AV bundle or bundle of His. This bundle is then divided into right and left bundle branches, which conduct the impulses toward the apex of the heart. The signals are then passed onto Purkinje fibers, turning upward and spreading throughout the ventricular myocardium. Electrical activities of the heart can be recorded in the form of electrocardiogram, ECG, or EKG. An ECG is a composite recording of all the action potentials produced by the nodes and the cells of the myocardium. Each wave or segment of the ECG corresponds to a certain event of the cardiac electrical cycle. When the atria are full of blood, the SA node fires, electrical signals spread throughout the atria and cause them to depolarize. This is represented by the P wave on the ECG. Atrial contraction, or atrial systole, starts about 100 milliseconds after the P wave begins. The PQ segment represents the time the signals travel from the SA node to the AV node. The QRS complex marks the firing of the AV node and represents ventricular depolarization. Q wave corresponds to depolarization of the interventricular septum. R wave is produced by depolarization of the main mass of the ventricles. S wave represents the last phase of ventricular depolarization at the base of the heart. Atrial repolarization also occurs during this time, but the signal is obscured by the large QRS complex. The ST segment reflects the plateau in the myocardial action potential. This is when the ventricles contract and pump blood. The T wave represents ventricular repolarization immediately before ventricular relaxation or ventricular diastole. The cycle repeats itself with every heartbeat.
Today I'm going to teach you a systematic way to review a 12-lead ECG. And the first step is quality checks, the one we always forget and don't have time to do, but they are so important to facilitate as the ICU nurse or anyone that captures the ECG. Please make sure that it's identified with a patient sticker so that we know exactly whose it is, and also to keep it safe in the filing system so that we can compare later with subsequent 12-lead ECGs. Please don't let the doctor take the original. Always make a copy so that the whole team has access to this information. Very, very important that I see is very neglected. Please write the reason why this ECG has been taken so that we can compare chest pain with no chest pain, for example. Please write chest pain 7 out of 10 or routine ECG, whatever the reason was that prompted you to do it. Please indicate the patient's vital signs, blood pressure, pulse, respiration, and saturation. Please indicate what medication the patient's on, any of the continuous infusions and any of the cardiac medication, or anything that might impact the ECG. Okay, please check the speed and amplitude, those quality markers I was explaining a little bit earlier. ECGs are most often taken at 25 millimeters per second, and that's a standard for most ECGs. If we've got a very fast rate and there are waves that are hiding within waves because they simply can't be separated, we might increase that to 50 millimeters per second or adjust the speed in some way to separate the waves for analysis. But the standard ECG is 25 millimeters per second. If somebody interferes with that on the ECG machine, you might be diagnosing the completely wrong thing. So please check that it is there. And also that little square calibration mark is there with the 10 blocks high for the amplitude and electricity millivolt metering. Also, please check that there's no interference. I've put some horrible examples up here. This is the first one, that A is probably when the patient was breathing very heavily or all the cables were over his rib cage. That will create that lovely swing there where we don't have a proper isoelectric line. B and C are showing electrical interference or maybe contact with metal, maybe a cell phone or something like that, creating that, or maybe even a sneeze. The green tick is what we're looking for. We're looking for a nice isoelectric line with no funny little interference waves, with clear PQRSTs. Step 2 is rate calculation, and you may wonder why you need to do this and take the time to do it, because the ECG machine works it out for you. Remember, these algorithms that the machine uses is not foolproof, it's just technology, and especially if you have an irregular rhythm, it might take a piece of a very slow part of that rhythm and give you the wrong rate. So correlate it with your patient's actual pulse and also the rest of your monitoring where various other pulses appear. Check that they're all agreeing, and then of course do your own rate calculation. There's many methods to do this. One of them is to use your rhythm strip, the last strip at the bottom of the page, which is usually lead 2. And once you've watched the video about the conduction system, it might make a bit more sense, because the view which lead 2 gives you is exactly the same angle, if you will, over the chest that the conduction system takes from the SA node, AV node, bundle branches. That same angle is the angle that lead 2 is, and therefore it is the best one to use as the rhythm strip. Okay, so look at the rhythm strip and you count your QRS complexes in that rhythm strip. Remember, it's a 10-second window, the rhythm strip. So however many QRS complexes you see there, or spikes, we will go into more detail, but the peaks, those R waves, count the amount of them and times by 6, because obviously 10 seconds goes into a minute 6 times. So if we want beats per minute, we need to count these beats and times them by 6. So for example, in that one that's on the screen now, we can count them as 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We times it by 6 and we've got an average heart rate there of 60 beats per minute. The alternative method is there on the side, where we count the small blocks in an RR interval. Remember, this will only work if the patient's rhythm is regular. If it's a variable space between beats, we're going to have different answers depending where we pick. So make sure the patient at least has a regular rhythm to use this method. You count all the small blocks. In this case, there are 19 small blocks between those two R's. You times that by 0.04 seconds. Remember, the one block represents 0.04 seconds on an ECG. The answer there is 0.76 seconds. So once you have the 0.76, we're going to say 60 divide by 0.76. So you'll probably need a calculator there, and it will give you an answer of around 79 beats per minute. You can check, there's many ways to do the rate calculation, but I honestly feel the first method I explained is the easiest. The next step is rhythm analysis. So we're going to check the intervals between the R waves. If they are consistent, we've got a regular beat, we've got a regular rhythm. If they're inconsistent, we of course have an irregular rhythm. So use the rhythm strip again, and you can measure the distance between each R wave and see that they are the same. A quick way to use this is use a piece of paper and a pen, and I think we'll release a TikTok video demonstrating how to do that. Okay, step 4, they don't often teach in nursing, but it's a very interesting principle called axis deviation. And it indicates the direction of the depolarization that's deviating to either the right or left side down those bundle branches. It could indicate hypertrophy, and cardiologists are very interested in this factor. If you are at that level where you feel you can take this on, check out Life in the Fast Lane. They have a great tool that can calculate this with you, and you can have a look at this slide where we look at lead 1 and AVF to determine if it's a left axis deviation or right. If we've got a positive lead 1, a positive AVF, it's normal, and all the other combinations are actually abnormal. But please have a look at this or send me a question if you are in our region and we do ward rounds in your ICU and you're interested in this. Please just put up your hand and come and ask, and we can have a look at this together. Okay, and then once all of those are done, we can start looking at the alphabet, the P, Q, R, S, T of the ECG, and sometimes even a U. Okay, so a good thing to do is take a pencil and label everything in the rhythm strip that you see. So make a few copies of the ECG so that we're not scratching all over the original, and we have our own copy and we can assess it properly. We're going to label each and every wave and assess it for its abnormalities. Another tip also is if you can't see the P wave in the rhythm strip, have a look at V2 as it is the closest to the SA node and right atrium. Okay, before we go into the alphabet and each wave, maybe now's a good time to just stand up, do a few squats or shake your head or walk around the table and just have a quick break. Okay, so let's start at the beginning, and we're going to start with the P wave. P waves are the first positive deflection on our ECG, and they represent atrial depolarization. Remember, depolarization, contraction, systole, all very similar. It's just meaning that the atria are now squeezing. The normal duration of a P wave is 0.12 seconds. And remember, our one small block is 0.04 seconds, which goes into 0.12 3 times. So we don't want it to be more than 3 small squares in length. The amplitude or height of the P wave has got different reference points depending where you look. This one that I found is quite cool, where it shows in a chest lead, so the V1s to 6, it shouldn't be higher than 1.5 millivolts, which is then 3, and then the limb leads 2.5 millivolts, which is a bit more. Okay, so a good rule of thumb just to remember is basically 3 by 3. We want it to be nice and rounded, and then we'll have a normal P wave. Okay, so now that we know what a normal P wave looks like, let's have a look at some of the abnormalities. All right, so we're starting with something you may not have heard of before, which is called P mitrale. It's a left atrial enlargement, usually due to mitral stenosis. And as you see in that picture over there, you've got something with almost like a notch-looking appearance. It's almost got 2 P waves overlapping each other in it. It's because of that enlarged left atrium and the electricity taking a bit longer to go through it. It will create 2 different sides. The left and right atrium is not happening at exactly the same moment, the depolarization I mean. And therefore you'll have a little bit of a delay and we end up with this M shape. So if you see this on your patient's ECG, just show your cardiologist and have a look. Be around for your echo that's going to happen, and have a look at the patient's mitral valve. Could be stenosed. The opposite of that, in some way, is P pulmonale, and that's right atrial enlargement, and that has got a peaked-looking appearance, usually due to pulmonary hypertension. Okay, one of our most common dysrhythmias that we see is atrial fibrillation, and it's the most underdiagnosed or underreported by nursing staff. Please don't let this one catch you out. So this is a very good time to pay strict attention. Okay, so the characteristics of atrial fibrillation will have an irregular heartbeat, and you can see the distance between those R waves are all over the place. They're all different. And on the isoelectric line, so that baseline that we often refer to, it's a fine fibrillatory wave because there's a whole lot of foci taking part and sending electrical signals down from the atria. Thank goodness we have an AV node that blocks a lot of these signals and only lets an appropriate rate through. Even though atrial fibrillation often goes quite fast, the atria are normally contracting at around 300 beats per minute. And our ventricles, thank goodness, due to that AV node, usually only let about 100 to maybe 160 through, giving us our elevated heart rates. Although slow AF also exists, you'll see this in our older population for sure. So don't let the rate catch you out, but often it is faster. It is a tachycardia. It is one of our supraventricular tachycardias because it originates in the atria and above. And in fact, we now know that AF comes from areas around our pulmonary veins. So if you go for a cryoablation for AF, they isolate the area around your pulmonary veins to block these inappropriate signals and block those foci from sending this inappropriate electricity down the atria. But this is what it looks like, so let's just go through it again. It's an irregular rhythm and it's got a fine fibrillatory baseline. There's no clear P wave. We'll also discuss it in cardiac output as well, but if a patient goes into AF, we lose what we call our atrial kick, and you'll have a little drop in your blood pressure, although sometimes it's not even symptomatic. Remember, it is very important to report this rhythm to the medical practitioners. If it is sustained, we need to anticoagulate. There is extra treatment involved, so please don't miss this one. Okay, and then almost the sister would be atrial flutter. This is distinguished by the sawtooth pattern. I don't know if you can see there, the baseline or isoelectric line has got a few P-looking waves, although they're not those nice rounded ones, but it looks like the bottom of a saw that you get at a hardware shop. That is the sawtooth that they refer to. And this rhythm is usually regular. It usually has a ratio. So in this example, if we count those atrial waves or P waves, although it's not a true P wave, but those sawtooths, we can count 1, 2, 3, 4, and then a QRS, and again 4, and a QRS, and again 4, and a QRS. So if you see this rhythm come up, you can then report that you are seeing what looks like an atrial flutter, and it has a conduction ratio of 4:1. It's a re-entry circuit that exists in the right atrium, and it's far less perhaps sinister than atrial fibrillation. Requires less electricity to cardiovert. Okay, so another P wave abnormality will be the whole group of rhythms called SVTs. I did mention it earlier, supraventricular tachycardias. They comprise, like I said, many different rhythms, including atrial fibrillation and atrial flutter. But the very fast ones that we see in our very symptomatic patients, often in the ED, are called AVNRT and AVRT, which are atrioventricular nodal re-entry tachycardias, which is quite a mouthful. We won't go into too much detail, but it's basically a re-entry circuit as well. It produces a very narrow complex because the bad electricity, if you will, or abnormal electricity is also happening in our atria and being conducted through our AV node, producing normal electricity in our ventricle and producing this nice narrow QRS, but at a very fast rate. They can be between 140 to 280 beats per minute, and the patient will feel probably terrible palpitations. They're very symptomatic. have a lower blood pressure, you can have a diaphoretic patient. Because of this very fast rate, they can even get a little bit ischemic and have a bit of chest pain. You won't see a nice P wave often because it is so fast. It often hides within the rest of our ECG. There's an example there of that notch that's happening, that's highlighted in yellow, which is probably the P wave that is embedded in other waves. But look for a very fast rate, a very narrow QRS, and of course all those symptoms. If a SVT is diagnosed, the treatment is vagal maneuvers, adenosine, and of course eventually an ablation. Okay, let's move on to the PR interval. So this is not a wave, this is almost a segment or a section of our ECG that we measure from the beginning of the P to the beginning of the QRS. It's basically checking the time from the onset of the P wave to the start of the QRS. So from where the atria contract, how long does it take for the signal to get to the ventricle? It reflects conduction through the AV node. The normal PR interval is between 120 to 200 milliseconds. You must remember this off by heart. So it's 0.12 seconds to 0.2 seconds, which is 3 to 5 blocks. If you just remember one number, would be the 5 blocks. Anything exceeding the 5 blocks will be too slow. Okay, so let's have a look. We are now talking about our atrioventricular blocks, or AV blocks, and the first one is called a first degree. The characteristics of this is a regular rhythm, but the PR interval is longer than those 5 blocks. So have a look with me now. If you count on this example from the beginning of the P to the beginning of the QRS, let's count it together. It looks like 1, 2, 3, 4, 5, 6, 7, 8. About 8 small blocks, which is way over the limit, and that is then diagnosis for a first degree AV block. So the electricity is taking quite long to reach from the atrium to the ventricle. However, this is normally asymptomatic. So why do we need to see it? Well, we need to monitor it. Remember, if our patient has some sort of ischemia or something going towards their conduction system where our conduction system isn't receiving enough oxygen, this could be a warning sign, and it could develop into something a lot more sinister. So just note it, point it out, write by your ECG rhythm on your chart, first degree, so that the next person can continue to monitor and see if it develops anywhere, or maybe it even resolves. But like I said, this is normally asymptomatic. The patient's blood pressure will be normal. They won't be complaining of anything. You would have picked it up on the ECG. Okay, for second degree, there's 2 different types, and as usual, these things all have different names. So the first type of second degree AV block is called a Mobitz 1 or a Wenkebach, or if you're an American, a winky back, which amuses me tremendously in South Africa. Okay, so what are the characteristics of this type 1 second degree, Mobitz 1? So we're going to measure our PR interval, and what you will notice is an irregular rhythm because the PR interval lengthens. In the poem, which I'll share with you a bit later, we say lengthen, lengthen, drop. What do you have? Wenkebach. So the PR interval increases progressively until a QRS is dropped. So the electricity goes through the AV node at a slower and slower rate until the AV node actually blocks one of those off. Okay, and you'll have this drop of a QRS. You can see there's a QRS missing, but before that we've got a PR interval that progressively gets longer and longer with each beat until that drop happens. So it's almost predictable in a way. Difficult to say whether this is symptomatic or not. some patients might have symptoms, some not at all. So you will have to assess cardiac output, neurological observations, blood pressure, etc. But please report this if you should see it. Okay, and you'll see as we go through the degrees, they get more sinister or more symptomatic and dangerous as we go on. So the next type is called the second degree AV block, or Mobitz type 2. It doesn't have a fancy name, just Mobitz 2. And this is also dropping of the QRS complexes, but the difference is it is now unpredictable. So what normally happens is you have a normal PR interval. There won't be lengthening. It will be that normal under 5 blocks or 0.2 seconds. And randomly you'll have a P wave and then a non-conducted QRS. So those gaps that we said where the QRS is missing, there'll just be an isoelectric line, which you can see in our presentation. We've got a rhythm strip there with 2 examples of this, a P wave with a non-conducted QRS. And because it is random, it is more dangerous. Different things can cause this: ischemia, different kinds of medications, for example, calcium channel blockers, beta blockers, digoxin, cordronix. So if your patient is having this, check what medication they're on and maybe have a discussion with your doctor as to should we omit the following doses or do an ischemia workup, for example. That brings us to the last one of the AV blocks, and that is the third degree, which is the most dangerous. It also has a different name called AV dissociation, which is actually a better name because it tells you exactly what it is. And that is no relationship between the P and QRS. In other words, no relationship between the SA node and the AV node. They're now firing independently. There's no communication. The AV node is our backup pacemaker of our conduction system, and it's not allowing the SA node signals to go through, but it's firing as well at a much slower rate just to keep you alive. Have a look at this rhythm strip here, and you can see the P waves, the SA node doing its best to fire off an electrical signal, but they're not being conducted. The AV node is doing its own thing, and you've got this wide QRS there at a very slow rate. These patients are very symptomatic. The rate is normally under 40 beats per minute, so we're expecting low cardiac output states, a bit of shock, low blood pressures, diaphoretic, often not enough blood going to the brain. There'll be some neurological symptoms, often confused and fighting you. This also happens a lot with patients whose pacemaker batteries die, that come in with those kinds of emergencies, or a severe ischemia on that conduction system. Older people with sick sinus syndrome that require a pacemaker insertion might present with this. Of course, our medications can cause this, but this is an emergency. So if you see this and you're a shift leader and you know you're getting a patient with third degree, put someone awake and sharp on this patient. Cannot be alone. Tight alarm settings on the monitor. This patient might need an emergency pacing as well. We can also try atropine, but usually on our ACLS algorithms, we will start an inotrope, and then if we have temporary pacemaking, which you all do, that's probably the best, our transcutaneous pacing, which I'll demonstrate in the units as well. If you're a shift leader and you don't know how to transcutaneous pace, you need to make an appointment with me ASAP so that you learn that skill to keep everyone safe. Another thing I just wanted to mention is normally what happens with all of these blocks is we'll put a temporary pacemaker in. Usually the cardiologist will do that in the cath lab, and then an ischemic workup will be done. So if we're at the acute part of this, they need to see whether ischemia is not the cause of this before they just put in a permanent pacemaker. It might be a reversible cause, so that workup needs to be done first. Okay, and then just for fun, and it might help you to remember, is the heart block poem. You can keep this on your phone. It's quite sweet, but it's a nice way to remember all these different kinds of atrioventricular blocks. So let's have a look at it together. So if the R is far from the P, then you have first degree. Longer drop, then you have Wenkebach. If some P's don't get through, then you have Mobitz 2. And if P's and Q's don't agree, then you have third degree. So the next part of our ECG is called the QRS complex and is made up of 3 different waves. It represents ventricular depolarization, or like I said, systole or contraction. Depolarization is the word we use for electricity. And that is via the bundle of His and the Purkinje fibers. The Q wave is the first negative deflection after the PR interval. It represents septal depolarization from left to right. The R wave is the first positive deflection after the Q and represents early ventricular depolarization down the bundle branches. This is, of course, the bulk of the QRS complex normally, and it's the biggest part of the wave. The S wave is the negative deflection after the big R wave, represents late ventricular depolarization through the Purkinje fibers up and around the heart. And where it joins and then becomes the ST segment is called the J point, which we'll talk about in a bit. So how do we measure the QRS complex? The duration is 0.8, which is 2 small blocks, to 0.1 milliseconds, which is 2.5 small blocks. So it's quite narrow. When you measure this, you measure from the beginning of that Q to the J point, or the end of the S. Remember, not all QRS complexes all over the ECG have the Q, R, and S. I've put an example here of the different formats that you might be presented with. For example, there's one with 2 R's, which is typical of bundle branch block. The one in the bottom right corner is the typical one, the QRS that we are talking about, but you might have no R at all and just have this very deep S, which they call a QS because of the 2 negatives together. But remember, the R is the pulse. It's the big R of ventricular depolarization. The next thing to have a look at is R wave progression, and this diagram explains it so beautifully. This is a slice through the chest, and if you look, you can see the orange heart, and the different colors represent the different parts of the conduction system and the way the electricity travels through our heart. The colors are then represented on that ECG there on the right. So let's have a look. We start with our P wave. We've got a blue wave there, and it's represented on the diagram by that number 1. And it's showing us the electricity being generated in that right atrium in the SA node. The purple is where the electricity travels on to the left atria, and it will form the back end of that P wave as represented on the ECG. Now what happens is the electricity moves from right to left. It happens very fast, and you've got an almost at the same time atrial contraction. But from the perspective of V1, our precordial lead that's on the right side of the sternum, which you can see in the diagram itself, all the electricity is going away from it, and you might have a biphasic P in V1 because of that. So don't be alarmed if you see that. Okay, so the next part, we have an intraseptal depolarization, which is represented by the Q wave on our ECG, and you can see on the diagram number 2 that red arrow. And this, the way in which the electricity moves is actually from left to right. It puts a electrical charge on that septum from the left side to the right side. So if you are V1, electricity is going to be coming towards you. You might have a positive Q wave, where we say a Q wave is the first negative deflection. Remember, all the other precordial leads are on the left side of the chest, so V1 is often the exception. So if you are V2, 3, 4, 5, 6, you will be seeing that electricity traveling from left to right and it will be going away from you as the electrode, and therefore will be negative. The same thing applies then to our R wave, which is represented by the green arrow there, number 3. And on the ECG, the big, tall green R wave is there. So that is through our bundle branches through to our ventricles. And as all the precordial leads see this part of the electricity moving, the R wave will get bigger and bigger. It's directed more towards the left, which is natural on our left ventricle. So you'll see in that little gray block, the R wave goes bigger and bigger. It peaks around V5 at its biggest amplitude, and then at V6, which is, remember, mid-axillary, it goes a little bit smaller again. So that is what they're talking about when they say R wave progression. It's the amplitude of those R waves through V1 to V6. And now you know why in V1 it's negative. It's going away from it on the right side. So let's talk about QRS abnormalities. And no, that bunny is not a mistake on my PowerPoint. That bunny needs to be there for the next part, which is bundle branch blocks. Okay, so how do bundle branch blocks work? So remember, in our conduction system, we have a left bundle branch and a right bundle branch delivering electricity to the left and right ventricles respectively. So if the one is slower than the other, we're going to get a double R wave. And what they look like on that ECG is bunny ears. Have a look at that RSR formation of that QRS complex. Do those 2 points not look like a rabbit's ears? So if you see rabbit ears on your ECG, you need to think about bundle branch blocks. What happens is, and we know it's very quick, but you'll have 2 different times at which the ventricles depolarize. One might be a little bit faster than the other because of the block, and it will generate 2 R waves. Okay, so besides the 2 R's, other characteristics might be the slurred S, which you can see in that V6 over there. The S wave, which is at the end of the QRS complex, is wide and very abnormal. Remember, with the slowed down time, or 2 separate times, we're going to have a longer duration on our QRS, greater than 120 milliseconds, so greater than 3 blocks in total. So if you measure the time from the beginning of the Q to the J point or the end of the S, and it's longer than 3 blocks, you'll probably have a bundle branch block. So now I'm going to teach you how to determine right or left. Okay, so the simplest way to teach this to beginners, and I still use this method myself, is the William and Morrow method. Okay, so what we do is we look at 2 leads, V1 and V6. Remember where they are placed? It's on the precordial leads, one looking more on the left and the other more on the right, the extremes of those. So if in V1 you see the double R shape, the bunny ears, but they are negative in this case, it looks like a W, but it's got those 2 points on them that looks like the ears. If you see a W, remember that in V1, W, we're looking at what's looking like a William. In V6, we also have a look at the R's, and we've got bunny ears in that lead in this example, and it looks like an M. If you see W in V1, M in V6, you've probably got a left bundle branch block. And what's nice about using these words as references or reminders is the middle of William has L's in it, which will remind you of left. Right bundle branch blocks are completely the opposite, and the word we use to remind ourselves is Morrow. So in V1, if you've got an M shape, a double R on the positive side creating the M, and then in V6 a W or a slurred S with those 2 points of the S wave creating a W shape, think of the word Morrow, and it might remind you of right bundle branch block because of the 2 R's in the middle of the word. If anyone needs more help with this, we can chat about it in the unit. And then just for our information. We used to say ST segments in bundle branch blocks cannot be assessed and should be ignored, but we know with clinical data, the patient's presentation, biomarkers, we have a lot of information to assess if someone has a MI. Left bundle branch block can often be caused by MI or be the way the patient presents. So there are new criteria that we can have a look at called the Smith modified Scarbosa criteria. I have put them on the screen, but I think this one is a good one for someone who's a little bit more advanced. They can check out these criteria and see how they apply. There are ways to use the ST segments to determine MI in bundle branch block. Just know that. All right, some more QRS abnormalities are pathological Q waves, which are very important in our MIs. We consider Q waves pathological if they are more than 1 millimeter wide, so more than 0.4 seconds. So just that first negative deflection that we talk about, if it's wider than one small block, it is deemed pathological. If they are more than 2 millimeters deep or 0.2 millivolts deep, they also classify as pathological. And then if we relate them to the size of the QRS complex, if they are more than 25% of the height of the entire QRS complex, we also call them pathological. So if they are deep. So have a look at the Q compared to the R, which is normally the positive side. And if it's more than 25%, you probably have a pathological Q. They're often more prevalent in leads V1 to 3, and they can indicate a current and even a prior MI. Remember, some MIs are not treated within the golden hour and you don't have complete reperfusion of the area and you have permanent damage, and that will be shown in the pathological Q. If you see this in a patient that had an old MI, it was quite a severe MI is what it's telling you, and there might be a little bit of dysfunction in certain areas. The next QRS abnormality has got lots of different names, and I'm sure you all have your own in your own environments. You might have heard of VEs, ventricular extrasystoles, PVCs, premature ventricular contractions, extrasystoles, ectopics, ectopy, ventricular ectopy. All of this means the same thing. And what it is electricity going through the ventricle from a focus that's not part of our normal conduction system, and it creates a big, ugly, bizarre QRS, wide QRS complex, which we can see in these examples. It always seems to come in too early if you look at the rhythm of the patient, and then there's a compensatory pause straight after it. These are very common in our ICUs, and I suspect they're underreported. This is often a sign of electrolyte imbalance, specifically potassium and magnesium. So if you see your patient getting VEs and getting more regular VEs, go and check your electrolytes. This is something you can initiate on your own as the ICU sister and replace. There's also different patterns that give us different names. For example, if you have two VEs straight after each other, it's called a couplet, which is demonstrated in that example. And then also if you have every second beat as a VE, in this one here at the bottom, you can see a normal PQRS, and then that funny, wide, bizarre VE with a compensatory pause, and then again a normal complex, and then a VE, normal complex VE. We call that ventricular bigemini. Remember, these big, wide VEs don't produce proper cardiac output, so your blood pressure can drop the more you get them. If you have a ratio of 1:1 like the ventricular bigem, we call it bigemini. Remember, bi is for second. If it's every third, we will call it a ventricular trigemini. And while we're on the subject of extras, I just wanted to put in the atrial ones, even though we're talking about QRSs. But on the subject of extrasystoles, this is a very common one in our ICUs that a lot of people miss. And it gives you an irregular rhythm and confuses everybody. But just like the ventricles produce sometimes this extra electricity and creates an extra contraction, a wide bizarre contraction. The atria do the same thing. There are foci in the atria that can cause this: a premature atrial contraction, atrial extrasystoles, atrial extras, atrial ectopy. It's all the same thing. And what usually happens is you'll see the PQRSs are going on perfectly like they should. We've got that nice rounded P that fits all our criteria. And then we'll see a P wave that's a different shape completely. Like in this example, it looks a very funny peaked shape almost. And that is electricity that's been generated by a focus somewhere in the atria and is managing to get to the AV node and being conducted down into the ventricles. They also usually come in a little bit earlier, and there's also a bit of a pause, a compensatory pause before the next P wave, true P wave from our SA node comes in. They happen at different times, and because of that, it creates this irregular looking beat. A lot of people have this as their normal physiology, so it's not something to be too concerned about, but it is worth noting always as the ICU sister so that you can see if it's getting worse. That might be an indication of something else. So on your ICU chart, if this was the rhythm I saw on the monitor, I would write SR for sinus rhythm plus AEs so that the team around me are aware the patient is having atrial extrasystoles. I've put also a nice comparison between the two over there that we can see nicely. So the premature atrial contractions will generate nice narrow QRSs because the electricity is coming from the atria, and after the AV node everything is normal through the bundle branches, but the PVCs that are generated in the ventricles follow a funny direction and you'll get this wide, bizarre, ugly QRS. Let's talk about the J point. So this part of the ECG is very important to get right because this is the part where we assess ST segments. But before we get there, let's see if we can identify the J point on these examples. So it's where the QRS complex meets the isoelectric line and it becomes the ST segment before the T wave. It normally has no charge and is flat on the baseline. But obviously when we're looking at our abnormalities, that will not be the case. But the point where to assess ST elevation or depression is on that J point. We also learned earlier that it's important to identify when measuring the duration of the QRS complex because the J point is at the end of the S wave. So have a look here and we'll point out the J points. They have been labeled on these 5 examples. The ST segment, as I said earlier, should be flat or isoelectric, so no charge whatsoever. This is the interval between depolarization and repolarization of the ventricle. And you can see on our PowerPoint slide, the ST segment is represented by that red flat line. So let's talk about the abnormalities, and starting with ST depression. So on the left-hand side, we can see where that J point is. If we are confused about where the isoelectric line is exactly, look for your PR interval. Your P wave will always be sitting on the baseline, and you can use that as a reference point with a ruler or a piece of paper to reference where the J point is in correlation with the baseline. And in this example, we can see that it is depressed or lower than the baseline with 3 blocks, maybe even a little bit more on that example. Any ST depression that is greater than 1 block or 0.1 millivolt is significant and should be reported. We have many more examples of what it might look like on the right hand side there. In all those examples, we've got a significant ST depression because our J point is underneath the isoelectric line. This also indicates probable ischemia, so a warning almost of an impending MI. So the arteries are most likely starting to occlude. We're starting to get a hypoperfusion to the myocardium itself in certain areas depending on which arteries, and our ECG is basically warning us that in that lead, in that area, the patient is most likely experiencing an ischemia. On the flip side, we have ST elevation, and we use the same principle. We identify the isoelectric line by looking at the PR interval. We can put our rulers or a piece of paper on that isoelectric line and then identify the J point, which again, just to remind you, is the end of the QRS where the ST segment starts. And anything that is elevated more than 1 block on a limb lead or more than 2 small blocks on a precordial or chest lead is significant and is indicating infarction, so that there's an active MI in that area on the heart. So let's have a look together at these examples of what this might look like. So we've got our isoelectric line once again where the PR interval is, and in all these examples we've got an elevated ST segment. Look how the J points are much higher up than those isoelectric lines. And remember the rule, 1 small block on a limb lead and 2 small blocks of ST elevation on a precordial chest lead must be reported, and it is indicating infarction. That one specifically on the bottom left hand corner that looks like a tombstone, you can use the colloquial language, those we call tombstones, because it's so hyperacute. The patient is reaching an infarct that could lead to death. Those are fatal signs. So our T wave is the last wave in our ECG. It represents ventricular repolarization. Our ventricles are so big that when they repolarize, it generates this wave, and it is represented on our slide with that green wave there. After the ST segment, we have a T wave. Very rarely you'll experience a U wave, which is much smaller, and it is the repolarization of the papillary muscle within the ventricle. Very rare. Don't worry if they're there or not. We're going to just end our teaching with the T wave. Our T wave also has abnormalities. The first one we're going to discuss is the inverted T wave, which is also a sign of ischemia, so an impending infarction where an occlusion has started in a coronary artery. T wave inversion may be considered as evidence of myocardial ischemia if it is at least 1 millimeter deep. So by inversion, they're saying that it's in the opposite direction. They are normally positive, so an upward inflection. If they are negative, they're in the opposite format, and we call them inverted. So if they're more than 1 small block inverted, it is significant and needs to be reported or acted upon. We also need to see them in 2 continuous leads that don't have dominant R waves. So if we see it in, for example, V5 and 6, we can say the T waves are inverted in that area. Another common abnormality of T waves regards potassium abnormalities. In hypokalemia, so when our potassium is too low, we might have a T wave inversion with an ST depression. And there comes that prominent U wave. So it almost looks like someone is pushing that T wave down. So you need to take all the information together. If the patient has signs and symptoms of MI and you have T wave inversion, it might be a sign of that, but we are going to check our electrolytes in any case regardless. If a patient that has a resolved MI starts presenting with this inverted T wave without any chest pain or any other symptoms or heart enzymes, biomarkers, check the potassium, it might be low. The opposite side, of course, is hyperkalemia. So potassium that's too high will generate a peaked T wave, and it almost looks like someone is pulling that T wave up. Our P wave flattens. We might have a PR interval that's a bit prolonged and a wide QRS complex, which shows almost abnormalities throughout the whole ECG. So whenever we have anything, we need to have a look at our electrolytes and our levels, and it could be electrolyte imbalance. Hyperacute T waves also occur in the early stages of an ST elevation MI. There's very good examples here. They often precede the appearance of an ST elevation or pathological Q, meaning they are very noticeable. They start to form that tombstone horrible shape that all makes us run very fast. Hyperacute T wave with an ST elevation MI. One of the most important intervals is the QT time, and this is the last one that we're going to look at today. It is measured from the beginning of the QRS complex to the end of the T wave, bearing in mind that not all QRS complexes have a Q. They often start with an R, so just have a look what you have, but it's from the beginning of that complex till the end of the T, and it represents the time in the ventricle from depolarization till the end of repolarization. This QT time is often neglected in our ICUs. No one really takes the time to have a look, but it's a very good warning sign of a sudden cardiac arrest looming. And if we've put the patient onto a medication like Cordaronex, we really should be taking the time to see how it's affecting our QT interval, QT time. If our patient is brady or tachycardic, we also need to correct the QT time, and I've given you the formula there. Some ECG machines can work this out for you, but it's good to be able to do it yourself. This is more for ICU trained staff or the shift leader, but anyone that's interested in this can do it with pleasure because it is so underdone. So let's just have a look. It starts becoming dangerous when we have a QT time that's over 500 milliseconds or 12.5 small blocks. If you're counting more than 12.5 small blocks, please alert your medical practitioner. Something needs to be checked or done or medications altered so that we don't run the risk of developing a Torsades de Pointes, for example. So we've done all the parts of the ECG. What we do need to have a look at though is what leads affect which area of the heart. So we've got our 12 leads, and we've represented them nicely here on this diagram in colors that show you which area of the heart they affect. Let's have a look first at our inferior side. So we call the inferior side of the heart also the right. It is supplied by the right coronary artery. Our conduction system, the SA node where it starts, is on the right hand side. And the leads that have a look at this side are 2, 3, and AVF. On this example, they're represented in green. And if we see abnormalities there, we're going to say it's on the inferior side. Our left side or anterior side has got different sections. So let's start with anterior septal. So V1 and V2 on each side of the sternum is showing us anterior septal. V3 and 4 are showing us anterior or left. This area is supplied by the LAD, left anterior descending artery, and is the main side of our heart, if you will, that generates cardiac output, our left ventricle. So if we see abnormalities here, we will refer to it as the anterior abnormality. We've also got lateral, and we've got two different areas, high lateral and low lateral. Low lateral will be the V5 and V6. It's on the left side of the heart, but more on the side. Lateral is the side, and it is supplied by the circumflex. We also have views of that lateral side with lead 1 and AVL. Those two are referred to as high lateral. This that I've explained now and these areas that are represented, you must know out of your head. You must know these areas if I wake you up in the middle of the night. So let's just go through it again. That boot shape that we often refer to, the green, is inferior. Lead 2, 3, AVF. Our anterior side is V1, 2, 3, and 4, and we separate that to V1 and 2 being anterior, septal, so in the middle, and then 3 and 4 being more left anterior. on the left ventricle. We then have our last side, which is lateral, and it is separated into high and low. And we're talking there about the circumflex artery on the left side of the heart, and it's represented by low lateral V5 and 6 and high lateral lead 1 and AVL. AVR has also got its uses. People are using it more and more, evaluating the ST elevation and everything, but I think for our level for now, we must just make sure that AVR is negative. So the QRS complex must be pointing downwards or inverted. It must be negative, because that's the view is opposing the normal direction of the conduction system in a normal patient. So if AVR is negative, we know that our ECG leads have been placed correctly. So just check for now that AVR is negative. There are also ways of assessing the posterior side of our heart. We're not going to show you that in today's video, but in future we will. For now, focus on being able to tell the inferior area, anterior, and lateral. Okay, so now that you have this amazing knowledge of the areas of the heart on the ECG, I'd like to propose this question to you. How many leads do you need to look after a cardiac patient? And what I'm referring to now is in the ICUs, on our normal monitoring, we have different numbers of leads. The most common is a 3-lead ECG, and that's going to give you Einthoven's triangle. The 3 leads we put on for normal monitoring. Do you think that's adequate to look after a cardiac patient? What are you going to get from those 3 leads? We're going to get lead 1, 2, 3, AVF, AVL, AVR. Are you going to get any V leads, V1 to 6? No. So on your monitor, you're not going to have any anterior views of your heart. If you're getting an MI or a cardiac patient, I suggest you at least grab a 5-lead ECG to be able to monitor those V leads, the precordial leads. 12-lead ECG is great, but it's not on all the time usually. So if we're going to monitor the patient, they're cardiac, and we want an anterior view, we should have 5 leads minimum to get V1, 2, 3, 4, 5. You're not going to be able to get all of them, but from your history, you'll be able to place that lead where you want it. As long as you have one of the V's, it's okay. One of the V views to get the anterior side, perhaps V3 or 4, because lateral we get elsewhere. Depends on the history, but just remember, if you're looking after cardiacs, 5 leads minimum. So that basically completes basic ECG knowledge. There's a few advanced concepts in there, but I don't think we should take it too far in this first lesson. What I'd like to do now is look at some 12-lead ECGs together. And the first one I've chosen is on the screen now. So I taught you the systematic way of reading 12-lead ECGs, and I hope that you will apply it in practice every time. For the sake of time, we're not going to do it every time on these ECGs. We're just going to pick out the abnormalities, but this is not the way to practice in an ICU. Remember, you're first going to look for quality. Obviously, due to POPI acts and all sorts of things, we're not going to display any patient names, but you need to check the identification of your ECG, the speed, the calibration of the amplitude versus time. You're going to check for no interference. You're going to check the reason why the ECG was taken, as well as the vital signs and medication the patient's on, every time. Okay, so let's have a look at this one and see if we can get the areas right. I'll give you a clue here. We're looking at MIs. So remember, with MIs, we're talking about infarct versus ischemia. Infarct, we're looking for pathological cues and ST elevation and the hyperacute T waves. For ischemia, we're looking for inverted T waves, ST depression. We said elevation or depression is significant at 1 block, and on elevation, we want 2 blocks on our precordial leads. So let's have a look just at our ST segments for now. Let's look at our inferior side, leads 2, 3, and AVF. The ST segment looks pretty flat. It looks the same as the isoelectric line where we're measuring our PR interval. Let's have a look at our anterior septal leads first, so V1 and V2. Remember, we're looking for the J point in correlation with the isoelectric line. So I think maybe in V2 we can say our J point is starting to elevate. Have a look further down in V3 and V4. I think there is over a 1 block elevation. We want it to be more than 2 blocks for our precordial leads, which I think V4 is showing us. So we can say this is an anterior MI. Don't just write on your chart MI or speak of MI. Be specific. Remember, the I of ICU is intensive and we need to know our details. So if we've got ST elevation in our V1 to 4 area, it's probably anterior, and if it's in 1 or 2, it's anterior septal. But in this example, I think it's fair to say that we're suspecting an anterior MI. And when we suspect anterior MIs, we expect the LAD to be the culprit. The left coronary artery, remember, separates into LAD, which comes in front of on our anterior side of our heart, supplying our left ventricle, and then the other split is the circumflex artery, which goes around the heart and is usually affects the lateral side, which is V5 and 6. So this patient would probably need biomarkers to be done, a full workup, an echo, and perhaps the cardiologist would take them to cath lab, and we could expect perhaps that there's some sort of problem with the LAD. Patient might need a balloon pump. We can expect cardiac output issues if the left ventricle is ischemic or infarcted. Right, so let's have a look at our next one. So you normally use a systematic review method to check out this 12-lead ECG, but I just want to pick out the abnormalities for teaching purposes. So let's see, we've got PQRSs, our rate is fairly regular. Let's have a look at our waves. If we look at our inferior side, let's start there with 2, 3 and AVF. What do we see there? We see inverted T's in lead 2. Lead 3, they're normal. AVF, they're pretty much normal. So remember the rule, we need 2 consecutive leads, so let's leave that. Let's look at high lateral, lead 1 and AVL. In both of those leads, we have inverted T's that could indicate ischemia. So that is significant because it's in 2 leads. Let's look at low lateral, V5 and 6, and they are in both of those, they are inverted, negative or underneath the isoelectric line. So there's definitely something happening on the lateral side of this heart. Let's have a look at our anterior side. In V1 it looks okay, V2 looks alright, V3 looks alright, V4 there's probably an inversion there, but we need more than 1 lead. So for this one we can say we have a lateral ischemia. Remember, we must check our electrolytes as well, but it could be ischemia on that lateral side or an ischemic circumflex artery. All right, so let's switch lanes and get out of the MI ischemia side and head to more dysrhythm side. This 12-lead ECG, the first thing you notice is that this rate is very fast. If we use the rate method of calculating on the rhythm strip and counting our QRS complexes and we times it by 6, there's about 40 QRS complexes in this 10-second interval. If you times it by 6, it's about 200 beats per minute. So this heart is racing. It is regular in rhythm and that fast rate. So I think it's quite unusual to get a sinus tachycardia that's that fast. Our SA node doesn't normally generate speeds of 200. I'd say around 180 or less. It depends who you ask. But if we're going to the 200s, we need to start thinking of those more sinister SVTs that are very symptomatic. You can also see there is a bit of abnormalities in terms of the isoelectric line, that it becomes a bit unstable towards the end of the ECG. But I suspect this patient is breathing quite heavily or in difficulty because of the symptoms. So it's not always possible to get a perfect ECG, but I think their respiration is actually affecting our isoelectric line towards the end. It's probably the best they could do. So let's have a look. Is there a P? Don't think we can see one on this ECG. I'm seeing the nice super narrow QRSs and then a T wave. The P is probably hidden within the other waves, and because of the speed we can't see them. This might be an instance where you might adjust the speed if it's required so that we can try and visualize the P wave, but just for the regular settings we are probably dealing with AV NRT, and this should be referred to then a cardiologist to manage. We might do the vagal maneuvers, we might administer this patient adenosine, and the patient might need an ablation to burn off these accessory pathways that cause these re-entry circuits where you have the bypass of the AV node basically and our supraventricular tachycardias. Let me draw your attention to this one. I hope you can see a nice wide QRS, which is abnormal. Is it a bundle branch block? Is it a pathological Q? What is happening here? I hope you guys have all seen this before. Can you see the little pacing spikes before each P wave and before each QRS? We've got a double chamber pacemaker. We've got dual pacing because we've got a pacing spike that then captures a P wave straight after, and then another little pacing spike that generates an ugly, bizarre QRS. Remember, if you've got electricity in your right ventricle from your right ventricular lead from a pacemaker, the electricity is not being generated on that nice conduction system through the AV node, bundle branches, through the Purkinje fibers. It's coming from a weird place in the right ventricle, and you get what looks like a right bundle branch block. But it's actually just electricity coming from the pacing. So I hope you've seen this one before. This one is very difficult. You cannot determine ST segment elevation. With pacing, you're going to have to go on history, biomarkers, other presentations. But I hope you can identify that this patient has a pacemaker. So let's have a look at this 12-lead ECG here. We're going to take our systematic approach in reality, but I just want to point out the highlights. So something that we can notice right off the bat is that there's something up with this ECG's rhythm. The spaces between the R's, or the RR intervals, are irregular. We're going to demonstrate this technique on TikTok a little bit later, but if you measure the distance between the R waves, they keep changing, which indicates to us that this rhythm is irregular. Let's have a look at the alphabet. Let's start with the P. Can we see the P wave? Can we identify them and label them? I cannot. We see a T wave, but throughout on that isoelectric line, we're just seeing a fibrillatory pattern, a fine fibrillation, which indicates atrial fibrillation. So this ECG has got two things happening. We've got the ischemia infarction side happening, and we've also got issues with our conduction system. So there's a problem with the plumbing, there's a problem with the electricity. I hope you can see by now that this is quite a slow rate. For some reason on this ECG they are using V5 as their rhythm strip. We normally use lead 2 because it mimics the direction of our normal conduction system, but let's use it for this example. So how many QRS complexes can we see in this rhythm strip? We've got 1, 2, 3, 4, 5, 6, and we're going to multiply that by 6 to get our rate, which is 36. So this is a bradycardia, or a slower heartbeat. Let's have a look. Is the rhythm regular? It looks pretty regular to me. Look at the intervals between the RRs. We can measure this a bit better. We're going to demonstrate that the way to do it on TikTok, but you can actually measure the blocks between each R. It looks pretty regular. Let's move on to the alphabet. Do we have a P in front of each QRS? Have a look just after the third QRS. There's a P wave, and then something non-conducted perhaps, and then another P wave, and then the QRS is there again. If we label it together from the start on the rhythm strip, I see a P, QRST, a P, QRST, a P that's then again longer with a QRST, a P, and then another P. So something's happened here where P wasn't conducted. It's not a lengthen drop scenario. This is actually a wonderful scenario because it kind of looks like it could be Wenkebach or Mobitz 1, the type 2 atrioventricular block that we call Mobitz 1, because our PR interval seems to be getting longer. But my difficulty with saying that it could be that is on that P wave where the QRS is missing, it picks up too quickly. It's not missing and then a normal P and QRS. It comes too quickly there. Wenkebach is typically irregular because of the missing QRS, where here our QRSs are regular, which makes me think that they're probably coming from the AV node. This is the backup pacemaker of your own heart that's trying to keep you alive and firing off electricity down into the ventricles. I suspect this is a third-degree block where there's no communication between the Ps and the QRSs. The SA node is firing independently from the AV node and generating the Ps, and the AV node is doing its own thing at a very slow rate, which fits in with this 36 that we're seeing here, and giving us these slow QRSs. So at the same time as the rhythm disturbance that we're seeing here, possible third-degree block or AV dissociation, we can see a massive ST elevation. Look at our inferior leads on lead 2, 3, and AVF. It's enormously elevated. We've got hyperacute T waves in our inferior side, and an inferior MI fits in with our conduction issues as well. We're going to have a dysrhythm problem if our conduction system is ischemic or infarcted and not receiving oxygenated blood to itself. Let's have a look at our anterior leads. Looks like reciprocal changes, which means we've got the opposite, the ST depressions in all of those. V1, 2, 3, 4, all depressed. V5 and 6 also have ST depression. In fact, V6 has elevation actually, but we need it in more than one. Our high lateral leads, 1 and AVL, have also got ST depression, and we've got a negative AVR. So I'd say the diagnosis of this ECG is ST elevation on the inferior side with a third-degree block or AV dissociation. This patient needs urgent cath lab, a temporary pacemaker, and for this probably right coronary artery to be opened up. I hope you enjoyed some of those examples and practicing with me. We're going to do that more in the future in our units, but those that are remote, please send me pictures of your ECGs. We can talk about it on WhatsApp or email. Remember, ECGs, I always say, are like push-ups. You can go to a push-up workshop and know how to do them in the best way, but you need to exercise and you need to practice them every day to become good at interpreting the 12-lead ECGs. So please, I'm encouraging you to practice with your friends, with your colleagues, with your doctors, whoever can help you with them. I'm willing. Let's make it a daily practice. Thank you so much for your attention. I've enjoyed this one tremendously. I feel like once you have ECG knowledge, you level up as an ICU sister. I hope you have taken some steps forward. Please drop me a WhatsApp or email if you have any questions. We're going to do our Q&A later on in the month. Look out for our short TikTok video reminders as well. And goodbye from JJ&J. Thank you.